Now, I would like to introduce our hematology keynote speaker, Dr. Tefferi. Dr. Tefferi did his med school from the University of Athens, Greece, followed by his residency at St. Joseph's Hospital in Chicago. Subsequently, he did his fellowship in hematology at the Mayo Clinic before joining the faculty there, and is currently a professor in hematology and internal medicine. He has had a long and illustrious career as a leading thinker and researcher in the field of myeloproliferative neoplasms. His academic and research achievements have been copious, with over 800 publications. Today, he will be talking to us about the science and practice of myeloproliferative neoplasms. Dr. Tefferi.
Thank you very much. Let me first thank the organizers for honoring me with their invitation in this important function. I have nothing to declare, and my objectives in this talk are to introduce you to the field of myeloproliferative neoplasms. And just for the sake of definition, the WHO classifies myeloproliferative neoplasms as one of the major categories of myeloid malignancies. And under the umbrella of MPN are several clinical pathologic entities as listed. But today, we're going to focus on the JAK2 related MPNs, and specifically polycythemia vera, which I would refer to as PV, essential thrombocythemia, ET, and primary myelofibrosis, which I would refer to as MF. And what I would like to do in this talk is give you a little bit of a background in classification and pathogenesis, and then spend most of my time in contemporary diagnostics, genetic prognostication, and treatment algorithms. The field of MPN has exploded, and it has become one of the most appealing entities, especially for young hematology and oncology trainees. And it all started in 2004, actually, when William Venchecker from France discovered the JAK2 V617F mutation. His observation, along with other esteemed leaders from Harvard, led by Dr. Gilliland, and also from Europe, the UK and Switzerland, they all reported their observations at the same time in 2005. And the JAK2 mutation, as you know, the JAK2 is an important signaling molecule that is important for ligand signaling from homodimeric receptors such as erythropoietin receptor, thrombopoietin receptor, or MOPL, and granulocyte colony stimulating factor receptor. The ligand receptor engagement results in phosphorylation of JAK2, which in turn results in phosphorylation of STAT5 and other signaling pathways, including MAPK and PI3K ACT pathways. The mutation in JAK2 results in constitutional activation of the JAK2. In other words, it's ligand independent, and results in the phenotype. Now, since that discovery in 2004, there has been other additional discoveries along the pathway of JAK-STAT or all JAK-STAT activating, and they include mutation in the thrombopoietin receptor MUPL and mutations in calreticulin or CALR gene. And all of these mutations ultimately result in JAK-STAT activation. The mutation in JAK2 occurs not on the kinase domain, but the pseudokinase domain. It appears that the pseudokinase domain usually inhibits kinase activation, and this mutation appears to abolish that inhibitory activity. The mutation in MUPL occurs near the the transmembrane and cytosol connection, and that results in gain of function, therefore resulting in, again, constitutional activation of the JAK-STAT pathway. The mutation in CALR occurs in the C domain, actually, which results in the abolition of the KDEL domain, which is important in localization of calreticulin in the endoplasmic reticulum. And it appears that the calreticulin mutation has an indirect JAK-STAT activation by binding to MUPL and then resulting in MUPL activation. Now, to just give you an overview, the JAK2 mutation occurs in almost everyone with polycythemia vera, as you can see here, and the 3 to 5% that are JAK2 V617F negative, most of them carry other JAK2 mutations, including exon 12 mutation. And this JAK2 mutation of V617F also occurs in about 50% of patients with ET or MF. The CALR mutation and the MUPL mutations are not found with PV, only rarely, but the CALR mutation occurs in about 20 to 25% of patients with PMF or ET, and the MUPL mutation occurs in about 5 to 10% of patients with ET or PMF. Now, it is important to recognize the fact that there are about 10% of patients with MF, about 15% of patients with ET that are negative for all these three so-called driver mutations, and they are usually referred to as triple negative patients. Are there other mutations? And the answer is yes. About 80% of patients with myelofibrosis carry other mutations, and the most frequent of which are ASXL1 and TET2. These mutations are also frequent in PV and ET, where such other mutations occur in over 50% of the patients. Now, on this slide, I have listed the spectrum of all other mutations, but it is important for you to pay attention to two points here. One is what the most frequent mutations are, and that's TET2 and SXL1, which means that whenever you have these patients, and if you were to do next generation sequencing on them, it wouldn't be surprising to find TET2 and ASXL1 mutations. But what I have done here is I have shown with a red arrow the prognostically relevant mutations among these. For example, in MF, the prognostically relevant mutations are ASXL1, SRSF2, and U2AF1 primarily, but also there is some prognostic contribution from CBL, CBL, IDH2, TP53, and EZH2. There are two other mutations that are important prognostically in blast phase, but not necessarily in chronic phase myelofibrosis, and they are RUNX1 and PTPN11. Prognostically relevant mutations in PV are ASXL1, SRSF2, and IDH2, but for all practical purposes, the only one to remember is SRSF2. Now remember, SRSF2 was also prognostically relevant in MF, and it also appears to be prognostically relevant in ET. So it appears that in ET, the spliceosome mutations, including SRSF2 and SF3B1, are prognostically important. So now we go to see how these scientific discoveries that have been remarkable have helped us reshape our diagnostic and prognostic approach to these diseases. Diagnosis at this point is pretty straightforward. In PV, since almost everybody carries a JAK2 mutation, whenever we suspect PV, we just order peripheral blood JAK2 mutations. These mutations are present in the peripheral blood as much as they are in the bone marrow. So there's no need to do a bone marrow just to do the mutation analysis. So in PV, if you find a JAK2 mutation, you're suspecting PV, it's probably PV. If not, then you wonder, well, could this be the 1% of patients that are JAK2 negative? And that is where a bone marrow examination and the serum erythropoietin level might contribute. And that might help you confirm whether or not it is a JAK2 negative PV. In ET, it's a little more trickier because these mutations are not specific to ET, and they can be found, this could be PV or it could be prefibrotic myelofibrosis, but at least finding one of the three mutations, which are carried by 90% of patients with ET, one of the three mutations, would confirm that you're dealing with a myeloproliferative neoplasm. And a bone marrow examination then might be necessary to distinguish ET from prefibrotic myelofibrosis or other JAK2 positive myeloid malignancies. So here, you might need a bone marrow examination for further distinction. In myelofibrosis, obviously, you need a bone marrow. But more importantly, here, when you do the bone marrow, do not forget to do the driver mutation screening to confirm that this is indeed an MPN. And there are some specific cytogenetic abnormalities, such as trisomy 9 and deletion 13q, which when present, suggest that you're dealing with primary myelofibrosis as opposed to another myeloid neoplasm that might be accompanied by reactive bone marrow fibrosis. Now, as I have shown you, it appears that if you use these mutations, things become simplified. And one of the sticking points has been, is this true ET, or am I dealing with another myeloid malignancy that can be JAK2 or other driver mutation mutated? Now, in ET, when you do a bone marrow examination, you would see that the megakaryocytes are very much mature appearing, and they're usually found in loose clusters. Now, contrast this with the bone marrow morphology picture in myelofibrosis, where the megakaryocytes are more angry looking. They are usually found in tight clusters. And a good pathologist can sometimes distinguish this, but not always. Obviously, in reactive thrombocytosis, you just find mature appearing megakaryocytes. In another JAK2 mutated myeloid disorder, the so-called RARS, or refractory anemia with ring sideroblasts, where 50% of the patients might carry the JAK2, in the bone marrow, obviously, you will see the ring sideroblasts. But more importantly, there is another mutation that is specific to this disorder, and that is SF3B1, and you can do a peripheral blood mutation screening for SF3B1 if you really suspect this. And don't forget CML that can present with isolated thrombocytosis, thus mimicking ET. And here, the bone marrow shows megakaryocytes that are dwarf and very small. But more importantly, this is easily ruled out by doing BCR-ABL. Now, I want to say a couple of things about that. First of all, BCR-ABL presence in CML is dominant. It is obviously 90% of the cells. But in other diseases like ET, other myeloid malignancies, you can have a very small clone, which is not morphologically apparent, but a small clone that carries JAK2 or MUPL, and that doesn't necessarily make it an ET diagnosis. It just makes it a CML diagnosis with a small clone of JAK2 carrying stem cells. Now, for most of us who are clinicians, we don't necessarily have to rely on the pathologist's view on whether the bone marrow looks like myelofibrosis or it looks more like ET. There are certain things that we can see from the peripheral blood that would help. In ET, there is usually no anemia. A slight anemia might be present in prefibrotic myelofibrosis. But most importantly, and I want to make this point clear, if you look at the MCV and RDW, these are always given to you along with the hemoglobin. Usually these are normal in ET. But if the RDW is increased or the MCV is decreased, then you should seriously consider the possibility of prefibrotic myelofibrosis or myelofibrosis for that matter. Similarly, the peripheral blood smear in ET is quite underwhelming. But the peripheral blood smear in prefibrotic myelofibrosis could show some leukoerythroblastosis, basically, which means that there are circulating nucleated red blood cells and immature myeloid cells, and there are some teardrop cells. Not always, but sometimes. Another very important finding in myelofibrosis is increased LDH. That's almost never seen in ET. And finally, when you are told that the patient has a JAK2 mutation, please don't forget to ask what the allele burden is, especially when you're trying to distinguish ET from other myeloproliferative neoplasms. In ET, the allele burden is usually less than 20%, much less than that. But in otherwise occult PV or prefibrotic myelofibrosis, the allele burden might exceed 20%. In other words, if it exceeds 20%, then you should seriously consider it. If it is below 20%, you cannot rule it out. Now, this is all good, and it's very simple if you are dealing with a clonal myeloid disorder and you look for the mutations. But for most of us in clinical practice, over 90% of the cases that come with rule-out polycythemia are not polycythemia vera, and that they're what we call non-PV erythrocytosis or secondary erythrocytosis. And the way I approach this is I always start with a serum erythropoietin level. And if it is subnormal and it's not PV, then I seriously consider the possibility of an erythropoietin receptor mutation. If the erythropoietin is increased, especially if it is markedly increased, then I seriously consider the possibility of an erythropoietin-producing tumor or renal artery stenosis or post-transplant erythrocytosis, and so forth. If the erythropoietin is normal, then I consider the possibility that it can either be congenital, other than EPO-R mutation, or it can be a compensated normal from secondary erythrocytosis that is associated with cardiopulmonary disease and what have you. Now, the most important thing here, if the erythropoietin is normal, is when you deal with the differential diagnosis, please always start with testosterone. Is the patient using testosterone for one reason or another? Because that usually answers the question. And by the way, that is not necessarily an indication to stop the testosterone. If the patient is getting a good quality of life with the testosterone, whatever the case might be, then there's nothing wrong with an increased hematocrit, which is not PV. And all the patient that needs is maybe one baby aspirin along with the testosterone supplement. Now, congenital erythrocytosis is very rare, maybe less than 10% of the cases that you suspect. And here I have listed all the possibilities, but most of them are extremely rare. But the only thing I would mention is if you are suspecting it, the mutations that are usually you want to look for are the VHL mutation, the von Hippel-Lindau, HIF2A mutation, and PHD2 mutation that are all listed in the slide for you. Now, let's go into survival and prognosis. And this is based on over 3,000 patients seen at the Mayo Clinic with a median follow-up of 20 years. And you can see very clearly that the survival curves are wonderful for ET and PMF. They're not terrible. In other words, these diseases are not like MDS or acute leukemia. And as you can see, ET and PV are clearly much better in terms of survival than primary myelofibrosis. And similarly, the risk of leukemic transformation is much higher in primary myelofibrosis, almost 10% during this follow-up period, as opposed to less than 5% in the other two. And also to note that polycythemia vera has a higher chance of transforming into myelofibrosis compared to ET. But interestingly, the risk of thrombosis is very similar along the three, with PV having the highest risk of thrombosis, followed by ET, and then followed by PMF. Now, when you compare the survival curves with a control population, the normal population, and here we use the Olmsted County, and clearly, even when we took the low risk, and this is a figure that we prepared, just taking low-risk patients with ET or PV, and clearly showing that life expectancy is significantly shortened, although these patients can expect a long life expectancy. Now, the most important prognostic factor in ET and PV is age. Advanced age in all these three diseases is worse with an older age. And if you look at young group of patients, for example, age less than 40 years, the median survival in ET and PV exceeds 35 years. And interestingly, the median survival in myelofibrosis, if you are below age 40, is 20 years. So just having a diagnosis does not automatically mean that you have to look into transplant for very young patients, because you have time to observe that patient for a long time. And the same is true for middle-aged patients between 41 and 60. And in older patients, of course, the age takes toll, and it's not necessarily that the disease is worse in older patients. Now the question is, are there other things other than age that can affect prognosis in these patients? Let's start with ET and PV. We just published an international prognostic scoring system that is actually enhanced by mutation information. We took 502 patients from the Mayo Clinic and the University of Florence, and we found that age obviously remains the most important prognostic factor. And interestingly, we also found that male patients live shorter than female patients. That appears to be true with any indolent disease. But other than sex and age, we found that patients with spliceosomal mutations, SRSF2 and SF3B1, fare worse. Now, I want to make a point here. Although these patients fare worse, you have to remember that first, the mutations are very infrequent, relatively infrequent. 7% of the patients with ET carry one of these adverse mutations. The second thing is we might be identifying occult prefibrotic patients, since these mutations are also quite prevalent in patients with myelofibrosis. In other words, if you have a patient with ET, do you need to do next generation sequencing? Well, I will probably not do it, because even if I find it, I can't do anything about it. As long as you communicate this fact to the patient, I don't think you need to necessarily do next generation sequencing in order to find these mutations and maybe unnecessarily increase the anxiety to the patient. But it might be a way of identifying prefibrotic myelofibrosis. Now, important in ET patients is another sinister mutation, the TP53 mutation. And these mutations appear to increase the risk of leukemic transformations in ET. So if you were asked, what are the adverse mutations in ET? It would be the spliceosomal mutations, SRSF2 and SF3B1, and then the TP53 mutation. In PV, again, age is the most important prognostic factor, but in addition, we have the SRSF2 mutation that appears to have a strong prognostic implication. And then in ET also, we found for survival, leukocytosis and abnormal karyotype are adverse features in this regard. Also in ET, we did find some other mutations that might increase the risk of transformation to myelofibrosis. But these mutations, specifically U2AF1 and SF3B1, are also mutations that are prevalent in myelofibrosis. And as I said before, this could be another marker of a prefibrotic myelofibrosis. And therefore, it will help you in generally appreciating what might be going on and deciding whether or not you need to do a bone marrow examination to look at morphological clues. Again, I want to emphasize, these mutations are not frequent, and you don't necessarily have to do NGS as long as you appreciate the possibility. Now, there are some patients who might want to know everything, and you could do the NGS. There are some patients who say, listen, what are you going to do about it other than just increase my anxiety? So you have to use the art of medicine here to decide who needs what. Now, I identified William Benchenker as the main person who discovered the JAK2 mutation and led to the explosion of the scientific advances we have in MPN. Equally important is another giant in the field, Tiziano Barbui from Bergamo, Italy, who's actually led all the seminal studies, all published in the New England Journal of Medicine, that have actually shaped our current practice in ET and PV. For example, the way we use hydroxyurea in high-risk ET and PV all come from a study that he published in 1995 along with his esteemed Italian colleagues. Our use of low-dose aspirin in both ET and PV stems from the randomized study that he published in 2004. And most recently, our insistence on aggressive phlebotomy to keep the hematocrit below 45% in PV also comes with another randomized study published in 2013. Now, as I have shown you, in ET and PV, survival looks very good, especially in young patients. And we don't treat these patients to prolong survival or prevent the complications of clonal progression, such as acute leukemia or myelofibrosis, because nothing has been shown to help in that regard, and the risks are relatively low. The reason why we treat patients with PV and ET is primarily to reduce the risk of thrombosis. The JAK2 mutation is equal to thrombosis. Anytime you have a JAK2 mutation, you have to worry about thrombosis. And in another seminal study, Dr. Barbui have shown that patients with ET can be distinguished in terms of their risk for thrombosis based on primarily two factors, which is the presence or absence of JAK2 mutation and age. Now, based on that, our current risk stratification in these diseases look at very low risk, intermediate risk, and high risk patients. Very low risk means that you're young, you have no thrombosis history, and you are JAK2 unmutated. In other words, you don't have these strong promoters of thrombosis. These patients might not need anything, including aspirin. They might not need it. Unless there is a cardiovascular risk factor, then you'd give them one aspirin. Now, if you are like very low risk, but you have a JAK2 mutation, then you go into the low risk category, and there the emphasis is on aspirin therapy. And I usually use one baby aspirin twice a day, since once a day aspirin does not secure coverage for 24 hours. Now, the intermediate risk is a new category that includes otherwise good-looking older patients. In other words, age above 60 years is not an automatic indicator of a prescription for hydroxyurea. If you are older, but you don't have a JAK2 mutation or thrombosis history, you could be managed just like your younger counterparts, just with aspirin. For high-risk patients, that means you either have thrombosis history or you're older and also have a JAK2 mutation. That is where we usually use hydroxyurea as a cornerstone of therapy. And depending on where the thrombosis history is, if it is arterial, we usually use one baby aspirin twice a day. If it is venous, That means in addition to hydroxyurea, you need systemic anticoagulation. In polycythemia vera, risk factors are simple, just advanced age and history of thrombosis, since everybody is JAK2 positive. And here, the treatment based on those low risk patients, meaning they are young and don't have any history of thrombosis, can be treated with twice daily aspirin therapy. And the high-risk patients, either they're older or have thrombosis history, are treated with hydroxyurea, and in addition, need to be treated with twice daily aspirin if a history of arterial thrombosis, or systemic anticoagulation with a history of venous thrombosis. Now, what if you can't use hydroxyurea for one reason or another? My second treatment of choice is clearly pegylated interferon. My third choice will be busulfan, which I think is maybe one of the most effective drugs in myeloproliferative neoplasms. And if all fails, and if the patient is showing signs of transformation into myelofibrosis, then ruxolitinib can be used. Now, the reason why I use the interferon alpha as a second treatment choice is it has been shown over years that it induces very good complete hematologic remission, good molecular remission up to 20%, although nobody knows whether this means anything in terms of longevity or protection from other complications of the disease. Now, believe it or not, my choice after interferon is busulfan. In our hands, busulfan has been extremely wonderful, and we have looked at over 1,000 patients with ET and over 1,000 patients with PV, and could not find any suggestion that busulfan is any more leukomogenic than hydroxyurea. We don't use anagrelide anymore, and we only use ruxolitinib if there is some suggestion of transformation into myelofibrosis. During pregnancy, we try to just stay with aspirin alone. If it is a high-risk patient, then obviously interferon alpha. And talking about interferon, there is now another pegylated interferon. You all know about Pegasus, which is nicer because you can give it every 2 weeks. The side effects may be a little better. And then the ropeg interferon, you can give it every 3 weeks, but otherwise everything is the same. Ropeg interferon is no different in terms of side effects or efficacy compared to Pegasus. The only difference would be that you might be able to give it every 3 weeks. And the other major important difference is the fact that this could be FDA approved, and therefore patients, you can get reimbursement for the treatment. Now in myelofibrosis, things are a little different. And this is primarily because not only is life expectancy shortened, but also there are complications of the disease that require attention, including huge spleen, as you can see, and constitutional symptoms. And our therapeutic options with myelofibrosis revolve around what your objective is. If your objective is to cure the patient or prolong the life of the patient, then the only thing that can do is allogeneic stem cell transplant. Don't waste any time. If your objection is just to palliate the patient, then you can either do observation, and then the treatment depends on what the problem is. If the problem is anemia, then there are anemia-effective drugs like thalidomide and androgens. If the problem is a big spleen, I usually start with hydroxyurea, but JAK2 inhibitors work very well. And ultimately, you might need splenectomy. If the problem is constitutional symptoms, you have to use JAK inhibitors because hydroxyurea doesn't work there. If the problem is extramedullary hematopoiesis, involved field radiotherapy is the way to go. And then, of course, there is usually experimental therapy. Now, in terms of prognostication, cytogenetics is the most important. I have listed the bad actors here for you. Inversion 3, isochromosome 17q, trisomy 21, monosomy 7, and so forth. And then this, along with mutations, if you just have that, you can have a very nice risk stratification simply by using molecular findings. And as you can see, if you are molecularly blessed, meaning that you have a type 1 CALR mutation, which is very good, you don't have any bad karyotype, and you don't have the bad mutations, then your survival at 5 years is 94%. And intermediate is not that bad, and here you are allowed to have 1 point, meaning that you could be CALR, type 1 CALR absent, which are most of the patients. And otherwise, then you have to seriously think about transplant. Now we used this for the molecular classification as I have shown you. But if you want to add some clinical features, such as anemia, constitutional symptoms, and circulating blast, then you can use a more refined prognostic scoring system, which we called MIPS 70, as published in JCO. And you can identify patients which are going to live forever, really long, but you can also identify patients that you have to rush into transplant with. And based on that, this is our treatment algorithm in myelofibrosis. If you are very low risk or low risk, first do no harm, just observe these patients. They can live a very long time, 30 years sometimes. If you have a high risk or very high risk, don't play around, take these patients to transplant. If you are intermediate risk, or if you have a low risk that is treatment requiring, then my preferred option is to put them in clinical trials. Otherwise, it depends on what the problem is, and I've already gone through what you should try to consider for what the problem is. Now, this is based on a study that is published in Blood showing that if you did transplant in low risk or intermediate 1 risk patient, you would probably kill the patients faster than the disease. If you do transplant in high risk or intermediate risk patients, then you probably can help those patients. Now, is there anything else you can do other than transplant to prolong? No, we've looked at it with the JAK inhibitors. That's the most popular in the treatment. We looked at it at ruxolitinib. And even the company-sponsored study didn't show significant improvement in survival. And we also looked at it with other JAK inhibitors like momelotinib. Absolutely no difference as to whether or not this patient received a JAK inhibitor as compared to those patients, historical controls that did not receive JAK inhibitors. What is important is whether or not they carry adverse mutations. The question is, can you overcome high-risk karyotype or adverse mutations? And yes, we've done a study in our center clearly showing that transplant, first of all, is better than no transplant, with a 50% survival, long-term survival. And this is true whether you are high-risk or intermediate risk karyotypically. And others have shown the same thing, again showing that the transplant benefit is not neutralized by high-risk molecular mutations or cytogenetic risk. And if you can't transplant the patient, then the question becomes, what can you do to palliate their symptoms? We've got tons of JAK inhibitors, approved are ruxolitinib and fedratinib. They all work the same in terms of spleen and symptoms. Momelotinib appears to also have an edge in terms of helping with anemia. The others actually make anemia worse, but it is not approved as yet. And obviously, you have to look at the side effect profile. It appears that fedratinib has the worst profile in terms of side effects. And at this point, the JAK inhibitor that is used up front when you are thinking of JAK inhibitor therapy is ruxolitinib. And the points that you need in your practice is that the indications is you have to have marked splenomegaly or severe constitutional symptoms that are resistant to hydroxyurea. There is no sense of putting everybody on ruxolitinib just because they have the diagnosis. You have to ask the question, is there an indication for ruxolitinib use? And obviously there are side effects. Patients become anemic or thrombocytopenic, and there are long-term side effects with immune suppression. And you also have to remember that you can't stop this drug quickly. You have to taper it off. And these are the unresolved issues, and these are one of my two last slides. And one issue is, how do you manage the spleen before transplant, since transplant is only curative therapy? Do you not, intervene with anything? Do you do splenectomy? Do you do splenic irradiation? Do you use ruxolitinib before, after? These issues are being addressed at this point. I don't think any hard conclusions can be made, but I can tell you what I'm doing right now. If the spleen is like less than 15 centimeter, then I usually don't do any specific intervention, just let the transplant take care of it. I am doing less and less splenectomy because it might delay the transplant process. I don't do splenic irradiation, but you can do it, and there are centers that do splenic irradiation. But what if I have to do something, I think using ruxolitinib would be the way to go before the transplant. What about palliative treatment options when the ruxolitinib fails? Well, the first thing I would do is increase the dose, and I don't care about the counts. It's all a matter of benefit and risk. If the patient is getting some benefit and kind of losing it, but maybe the platelets are a little low, I still try to increase the dose before I go somewhere else. Splenectomy always remains, experimental therapy always available. Fedratinib, I said don't hold your breath because we have not had, because we've done all these studies, we've initiated all the studies, we have not had that much luck in patients with ruxolitinib failures. And these patients are very sick, and the platelets are very low, very difficult to use fedratinib. And then finally, how do you manage blast-phase disease? And that is a terrible disease, as you can see. And when we looked at 410 patients between Mayo Clinic and the Italian groups, we were able to show that if you don't do anything, survival is dismal. If you do something and get a complete remission, then you can prolong survival, but the long-term survival remains dismal. So what is the intention to how to manage these patients? Try to get them into CR or transplant. That's how you can prolong. The question is, how do you do that? With intensive chemotherapy, we were able to achieve 35% ER. With just hypomethylating agents alone, 4%. But most recently, we looked at retrospectively our experience in 14 patients, of which 12 are evaluable. And the addition of venetoclax to HMA resulted in what appears to be a more superior complete remission rate as opposed to HMA alone. So I think this is a very reasonable drug to use in trying to bridge into transplant or give patients some time so that they can manage their affairs. Now, finally, I have included two last slides for your pursual in the slide, but I'm not going to talk about them because none of them are exciting. These are all experimental drug trials that were presented at ASH. None of them are exciting. And the question you might ask is, well, if you don't think that they're exciting, would you give it to your patient? Well, the question is, I am not my patient, and patients have different agenda. And some patients don't want to sit around and wait for something better to come. They want to try whatever there is. I respect that patient. But if it was me who had the disease, it's very unlikely that I would participate in any of these trials because they're not that exciting. So I will leave you with that, and thank you very much for your attention.
I know we're short on time, but we do have a question from one of the viewers. Where do you think the impetus for future research in MPNs is expected to have the maximum impact on patient outcomes?
That is a very profound question. And the person who made that request clearly knows that there is no good answer to that. I think that the transplant data is very encouraging. So I think we should stay with the possibility of transplanting patients who are high risk. But in terms of palliative treatment, there are so many drugs, there are so many targets, and everybody is trying to make money. Everybody, as you know, that the drug companies' interest is to get their drugs approved and make profit. Clearly, this is the elephant in the room. And the way these drug companies are designed is to accelerate and enable the approval of this drug, not necessarily to change the lives of our patients. So I would plead with the drug companies to give physicians the leeway to decide on the design of the drugs, rather than the companies designing the drugs and making sure that it fulfills the FDA requirement and therefore it will get approved. So if science is to drive the way, then drug companies have to rely more on scientists and clinicians to come up with the clinical trials, to come up with the protocols, to write the protocols, and actually to publish the protocols. Right now, the companies are the ones who are writing the papers, who are doing everything. So that has to change. If that habit is not changed, if that paradigm is not changed, I don't see too much progression, because we're just going to stay with drugs that make money, but not necessarily help. So that's my plea. That's what I see as the future, that clinicians and scientists taking control of the research and the clinical trials.
Certainly a tough situation. Thank you, Dr. Tefferi, for the talk. We greatly appreciate it.